The video, I'm going to show you a couple segments of videos where I think it's been most clear. You can do non-invasive positive pressure ventilation, which is basically your CPAP and your BiPAP that we talked about a little bit last time. So your regular breathing with tidal volume, if you think about it down here, you take so much of a breath in when your diaphragm moves out, and it goes down. Patients with CPAP have when you read your books in different books, they talk about CPAP is related to the expiratory positive pressure that goes on. And I think of this as PEEP. PEEP is a little bit of extra pressure that's continuous in the cycle. So when people have obstructive sleep apnea, you learn in pulmonary, CPAP just gives you a little extra pressure to keep everything open, the alveoli, so they're not deflating. I think of this basic CPAP as basically PEEP, but the difference between CPAP and PEEP is CPAP is normally they're breathing on their own. And when you talk about PEEP, that's usually with the ventilator, that the ventilator is actually doing the breathing as well as maintaining the pressure. So CPAP is spontaneous respirations the patient would do. BiPAP is actually a trademark word, so you'll never hardly ever see the word BiPAP written in any of the books because it's like saying Coca-Cola, versus just cola. So they don't like to use that trademark word. But basically BiPAP also has an inspiratory positive pressure as well, which, the basic level of it gives you a little bit more. And the biggest thing I think you need to know, wink, wink, for a test question would be that which of those two decreases CO2 levels, and the answer is BiPAP. BiPAP can decrease your CO2 level. That can become important if you're in the ICU and you want to help wean a patient or you're worried about re-intubating a patient. You may want to try BiPAP for a little bit if there's some respiratory acidosis going on in that patient. If you've never seen a patient with a CPAP or BiPAP device, they're all the same. They're connected to a little device that you see here that controls all the pressures. This can be done on the ventilator as well. So if you're weaning a patient off the vents that's doing all the breathing, you can put them on a CPAP mode that basically allows them to breathe on their own and just gives them a little bit of pressure, a little bit of extra. We call that the PEEP side of it. Advantages of the non-invasive positive pressure: it reduces the need for sedation, preservation of the airway protective reflexes, decreases the incidence of nosocomial sinusitis and pneumonia, increased patient comfort compared to having an ET tube in. This is all compared to the ET tube and shorter lengths of stay in the ICU and hospital when you can get away with just using these for oxygen. Disadvantages: claustrophobia. If someone's never had a mask on before, now you put a CPAP or BiPAP mask on them, they may hate it, they may be trying to rip it off. They are agitated, they're sometimes not with it fully mentally, they don't even know what they're doing, they're just trying to pull it off, so it could be a problem. You may need to sedate the patient a little bit more. Increased workload for the respiratory practitioner. Facial nasal pressure lesions can occur, the tightness. It's not uncommon to get rashes or such around there. The fluid, this is humidified air for the most part, so you can get infections, skin infections, pretty rare, but it could occur. Inability to suction the deep airway, and gastric distension. As you can imagine, the increase of pressure, it may build up into the GI tract, and you may get vomiting, you may get nausea with that, so you have to think about it. Some contraindications: if they have cardiac or respiratory arrest, we're not going to be putting them on any kind of CPAP for that. Any hemodynamic instability, we need to stabilize the patients with the drips as well as respiratory-wise. Myocardial ischemia or arrhythmias, inability to protect the airway, high risk of aspiration, severe hypoxemia, facial trauma or burns, or significant agitation. All of this is not very helpful. So there's a couple videos here. This first one, if you can just bear with me, and try not to just play around on your computers if you can. I'm going to fast forward this to the most important part. When you look at it yourself,
you've got a bunch of buttons, and that's kind of an option. But this is the basic anatomy of an endotracheal tube. Now, of course, we just talked about the ventilator. That's got a bunch of buttons and whistles and things we're going to talk about in a little bit. Okay, so going back to our patient again.
You all hear it okay, or turn it
Got our endotracheal tube. Got our ventilator. Okay, so what's the purpose of this ventilator? purpose of the ventilator is to maintain homeostasis between the two gas concentrations that we're talking about here, which is carbon dioxide and oxygen. Okay, so oxygen is being put into the patient and carbon dioxide is coming out. And for the most part, we want to keep those close to normal. There's some exceptions to that. Here's the point though. There's many different ways to put air into somebody, okay? We can say we're gonna put air into somebody based on volume. Okay? So we're gonna put a certain X amount of volume into somebody and then let it come back out. That's one way of doing it. Another way of ventilating somebody is saying, we're going to inflate them to a certain pressure. So we're gonna have this ventilator put a certain amount of pressure into the patient, and then when that pressure is released, then it's gonna come back out. So we can do that. Now, we can do it at a certain rate. We can do this fast, and we can do it slow. Okay, so in other words, how many breaths per minute. We could also adjust the flow rate. So in other words, yes, we can put a certain volume in, but we can give that volume slowly, or we can give that volume very quickly. Okay? The other thing is that we can do is we can decide how much pressure to leave in there at the end of when we put the air in, and then we can decide how much pressure to leave in there after we're done putting the air in. Finally, we can decide how much oxygen we want to put in there. How much? We can put a lot or we can put a little. Now, just to further complicate this, just to kind of see where we're going with this, we can have the ventilator be in charge of when the patient gets a breath, or we can have the patient be in charge of when they want to get a breath. So think about all of these different variabilities, and now you can quickly see how there are so many different ways that you can ventilate somebody, and each one of these ways is a different mode of ventilation. You may have heard of these before, like AC, or SIMV, or pressure support, or CPAP. These are all different modes, and we're going to go through some of these modes and show you how it makes sense about how this is working. Okay, so here's our system. Over here we've got the ventilator. Here we've got the tubing that goes to the endotracheal tube down into the lungs. And we've got our balloon here filled with air to make sure nothing else gets down there, and we're ventilating our right lung and our left lung. So let's talk about the first mode of ventilation, and this will become important later. The first mode that I want to talk about is AC. Okay, the other way we call it is assist control. The other name for it also is continuous mandatory ventilation, or CMV. Now this is the most common mode of ventilation that you'll see, especially on a medicine floor or medicine unit. The key here is that the patient triggers the vent. How does that happen? Well, the patient takes a breath in, and therefore there's a negative pressure here, which causes a negative pressure to be sensed here at the ventilator. The other way you could sense it is by flow, if there's a flow that actually goes through here by the negative pressure. Now, as soon as the ventilator picks up on that negative pressure, it's going to deliver a specific volume. Okay? And so there's an actual dial on here, okay, where you can actually turn the knob to a specific volume, where you can enter it in. And that volume can be anywhere from 500 cc's all the way up to 600 cc's usually. The ideal way of ventilating somebody would be around 8 milliliters per kilogram, ideal body weight.
Wink, wink, 8 mLs per kilogram.
So anyway,
Ideal
whatever
body
that
weight.
volume is, it's
I'll
going to
stress
deliver
that.
that specific volume in AC mode ventilation. Okay? Now, the patient can trigger it. You could also set up a backup mode or a rate. What does that mean? If I set the rate to, for instance, 12, because there are 12 5-second intervals in 1 minute, that means every 5 seconds, the ventilator will give a breath to the patient of a specific volume every 5 seconds, only if the patient does not take a breath. If the patient is breathing above 12, then the ventilator will only give breaths when the patient triggers it by trying to take a breath in. In other words, if you set the mode to AC, set in a volume, and set a rate of 12, the patient can never breathe less than 12 times per minute.
So this mode is really nice, AC mode, and he said it's like the most common one used in ICUs everywhere, because it can be done either on the awake patient or the totally sedated patients. Meaning they can initiate, if they are awake, when they go to take a breath in, that negative pressure inside will trigger the actual vent to release the certain amount of volume that you have preset. You tell them what the tidal volume is. How do you figure out what the tidal volume is? Right here, 8 mLs per kilogram, ideal body weight. Okay, so that's how you set it at. And then the other number you set is how many breaths per minute do you want this machine to go off? As he said, if he sets it at 12, if that's the number, then 60 seconds in a minute divided by 12, you know every 5 seconds that device is going to be going off. So those are basically the numbers that you're setting for this. This works great also if the patient is 100% sedated. So they're coming out of the OR, they're not breathing at all on their own, maybe they're too sedated, and the machine will do all the work. So either the patient can set it up, but it's a volume. This is a volume issue. You determine what the volume is.
Now, there's something that you should understand about this which is very important. You may recall from chemistry an equation that says PV equals nRT. Now, in this system, temperature is constant. R, of course, is always a constant. N is a constant. And so the thing that you must realize is that pressure and volume are inversely proportional to themselves. In other words, as the volume of a gas goes up, the pressure goes down if you have the same amount of gas. However, the other way of looking at this is compliance, which I'll abbreviate as a C. Compliance is equal to the change in volume over the change in pressure, which means to say that if the pressure changes a little bit and the volume changes a lot, then you have a very compliant lung. If you don't have a very...
All you need to remember is that there's an inverse relationship between pressure and volume. If you decide to go up on the tidal volume, that automatically means the pressure is going to go down a little bit, and vice versa. In a few moments, you're going to hear them talk about pressure modes. Right now, we're in the volume mode of AC. So I like this, how he explains it.
Compliant lung. It's going to take a lot of pressure to make just a small amount of change. Here's the point. The point is that these set of lungs have a specific compliance. And if you are delivering a specific volume into these lungs, you are going to get a specific pressure after you deliver that volume. That pressure can change depending on the compliance. The point of this is that you need to have a readout that tells you what the pressure is in that lung, so you can know what the compliance is. So in other words, in this mode of ventilation, you set the tidal volume, and the ventilator will tell you what the pressure is. So you're setting the tidal volume, you're setting how much volume of gas is going to go into the lung, and based on the compliance of the lung, it will tell you what the pressure is.
What he means by compliance of the lung is not only is the lung working and inflating and deflating, that's what it basically means, but it also has to do with the chest wall and your muscles. There's lots of people who have muscular problems, right, and they're not breathing as well, Guillain-Barré or other issues that you'll deal with in medical ICUs, for the diaphragm's not working. So there's a lot of different factors. I'm not going to get into all that, but it kind of makes sense. All of this plays into it. It all comes down to two things: volume and pressure. Remember, nothing else, volume and pressure. And volume is generally about 8 mLs per kilogram.
If the compliance of the lung goes down, then typically you'll have higher pressures. If the compliance of the lung is very high, in other words, a very compliant lung, then your pressures are going to tend to be on the lower side. Now, let's make this converse to pressure control. In pressure control, what we're doing is we're setting a pressure. In other words, we're going to decide how much pressure we're going to ventilate this patient with. And so, as you can imagine, if we're setting a pressure, there is a specific compliance to this lung, depending on what state it is in. And if we set a certain pressure, if the compliance of this lung is very low, then you can imagine we're going to have lower volumes. However, if the compliance of this lung is very high, then we're going to have higher volumes. Because remember, compliance is equal to the change in volume over the change in pressure. So in pressure control, you can also have the patient or time triggering a set change in pressure. And depending on the compliance, the volume can change. And so the key here is that you need to have alarms set up, and you need to know and understand what those alarms mean. What could happen here, let's for instance say, in a pressure control situation where you're giving a specific pressure, if the compliance of these lungs somehow drop precipitously all of a sudden because of some pathology which we'll get into, you will notice that the volumes will drop. You would want to know that, and so you could set an alarm on the lower side of the volume so that if the volumes did go down, an alarm would go off saying that you're not ventilating. Conversely, if you were back in our previous mode, which was assist control, and you're setting a certain volume, if the compliance of the lung dropped in that situation, then as you would realize, the pressure would start to go up because you're trying to put a set amount of volume into a low compliant lung. And when that happens, the pressure goes up. The pressure would then trigger an alarm. So the point here is, in pressure control, you're setting a pressure and your output to read is your volume. In AC, it's the flip of this.
So for the next one, I'm only going to show you a couple snippets, but I am going to ask that you just read it or watch it yourself. But the important things I'm going to highlight.
In this video, we will review the basics of mechanical ventilation. Some concepts will be simplified for learning. Or with lung D plus 2.3 times height in inches my volume for a 5'9" tissue mass does not affect lung volume. The formulas for these estimations are a 5'9" male at 70 kilograms is approximately equal to the lung volume for a 5'9" male at 150 kilograms. In other words, the soft tissue mass does not affect lung.
This is a kind of an important slide because it shows you the standard patient of 70 kilograms. You know, most of our patients are not 70 kilograms. But this is kind of how someone who's about 5'9", 100 centimeters, we always calculate by centimeters, 70 kilograms would have that. This is the calculation how it was determined.
Volume. The formulas for these estimations are, for males, predicted body weight in kilograms equals 50 plus 2.3 times height in inches minus 60. For females,
now you do not need to memorize this, but I just want to show you.
Kilograms equals 45.5 plus 2.3 times height in inches minus 60.
This is what you're doing if you're taking care of the ventilators to figure out, their predicted kilograms, the ideal body weight. This is the formula that you would use. You don't have to memorize it, I just wanted to show it to you once.
The good way to predict a patient's weight is to start with estimating. A good set of numbers to keep in mind is the following. For a 5'9" or 175 centimeter male, a tidal volume of 500 cc's is equivalent to 7 cc's per kilogram.
So if you remember nothing, wink, 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 red right there. 5'9", standard, patient is about 175 that we just saw. That's about 500 cc's tidal volume. So right now, breathing at rest right now, which is about 7 cc's per kilogram. Wow. So that's kind of the one standard number if you wanted to think about that if you're in the hospital. Keep that in your back pocket.
Using these numbers, you can adjust the tidal volume up or down based upon height until you have time to cross-check by formula or table. Respiratory rate is the number of breaths taken per minute. In a patient without other physiologic derangements, respiratory rate is approximately 10 to 14 breaths per minute. Remember the following equation. Tidal volume multiplied by respiratory rate gives us a minute ventilation.
This is another classic thing you may read about minute ventilation. It's your tidal volume
A
times your
normal minute
respiratory rate.
ventilation for you and me is approximately 4 to 6 liters per minute.
That's basically what it comes out to, 4 to 6, so about 5 liters, I think about every minute is your normal minute ventilation. Just so your cardiac output is 5 liters, your minute ventilation is 5 liters as well.
FiO2, or inspired fraction of oxygen, is the percentage of oxygen in the air that is delivered to a patient. When first placing a patient on a ventilator, it is reasonable to start with an inspired fraction of oxygen at 100% and titrate down later. The goal is to use the minimum FiO2 required to have a PaO2 greater than 60 millimeters of mercury or an oxygen saturation greater than 90%.
Remember the last class I think I told you, there's that relationship when the pulse ox is 90%. What does that equal as a PaO2 if you do a blood gas? 60 right there. And you never want to keep anyone below that, always above that.
Positive end expiratory pressure, or PEEP, is a concept that is often initially confusing. PEEP, applied by the ventilator, is called extrinsic PEEP since it is produced by the ventilator. PEEP is a positive pressure measured in centimeters of water that is constantly applied to the airway, not only at the end of expiration. Therefore, the pressure in the lungs is never allowed to go below your set PEEP level. In this graph, the minimum pressure is 5. Any pressure generated with inspiration will be added on top of your PEEP value. With normal exhalation, the end expiratory pressure following end exhalation on a ventilator should be equal to your set PEEP value, here a value of 5. The role of PEEP is to help alveolar recruitment. Some alveoli are easier to inflate with the breath than others. PEEP helps keep some marginal alveoli open so that they are available to participate in gas exchange.
Decreases atelectasis.
Many of you are
Improves
familiar with
oxygenation.
or have heard of the concept of CPAP. CPAP is continuous positive airway pressure applied to a non-intubated patient via an external face mask. CPAP is the same as PEEP, except CPAP is applied via face mask and PEEP is applied via an endotracheal tube.
I'll be honest, I don't think I ever learned that concept in school. It's a simple thing. It's like, oh, when the
CPAP
light
is
bulb
most
goes
often
off.
used in patients with obstructive sleep apnea who have collapse of their airway soft tissues during sleep, leading to airflow obstruction. CPAP has been described as an airway stent to keep these tissues from collapsing. Ventilator settings are changed based upon a patient's respiratory compliance and gas exchange. Respiratory compliance, or the lung's ability to stretch or expand, is assessed by measurements of peak and plateau airway pressures from the ventilator settings from the ventilator based upon our patient's needs. That leaves us with 4 potential variables to adjust: tidal volume, respiratory rate, FiO2, and PEEP. Here's our first example. You obtain an ABG, pH of 7.28, PaCO2 of 55, and PaO2 of 100.
Hey, what is that? So you have acidosis, the pH is below 7.35, and then you look at the acid component, which is the CO2, and it's greater than 45, right? 35 to 45. So you're done. Respiratory acidosis, right? how much you think you could fix this if they're on the ventilator? Increase the rates. If they're breathing off more times a minute, then they'll help get rid of some of that CO2. That's one of the ways, yeah.
Let's look at what this gas is showing us. At 7.28, the pH is acidotic. Next, we look at the carbon dioxide level, which is elevated, 55 from a normal value of 40. We know that this is likely contributing entirely or in part to our patient's acidosis. The PaO2 is 100, which is acceptable and does not require adjustment at this time. We conclude that our patient has a respiratory acidosis with adequate oxygenation. Which two variables can we change to compensate for this? Generally speaking, for derangements pertaining to arterial CO2, we change the patient's minute ventilation, which is respiratory rate times tidal volume. Therefore, for this patient with a respiratory acidosis, we will likely start by changing his respiratory rate. We could alternatively change his tidal volume. However, assuming that we have chosen an appropriate tidal volume for our patient's size, we usually change our respiratory rate first. In order to compensate for metabolic acidosis, we can increase the minute ventilation by selecting a more frequent respiratory rate or choosing a greater tidal volume. Let's look at another blood gas example. You obtain an arterial blood gas on a different patient. pH of 7.4, PaCO2 of 40, and PaO2 of 40. What is this blood gas showing us? At 7.4, the pH is neutral. Next, we look at the carbon dioxide level, 40, which is normal and acceptable, particularly since our pH is normal. PaO2 is 40, which is too low and requires adjustment. We conclude that our patient is hypoxemic with adequate ventilation. Which two variables can we change to compensate for this? Generally speaking, for derangements pertaining to arterial O2, we change the patient's FiO2 or PEEP. Therefore, for this patient with hypoxemia, we will likely start by changing her FiO2. We could additionally change her PEEP. What these examples illustrate.
What is the normal FiO2 in the air right now? How much oxygen is in the air back from 7th grade? About 21%. That equals FiO2 of 0.21. Okay, 21%. So we're starting at 100% usually. Let's say this patient was on 40% FiO2, then you can go up to 60% or 70 or whatever you want. But think of it that way. If you're going to wean a vent, usually we wean them down to at least 50%. And then we'll see how we'll put them on some CPAP mode for a little bit. And if they're doing okay with their gas, we'll extubate them out.
Is that generally speaking, ventilation or carbon dioxide exchange and oxygenation. However, more exceptions to the PaO2 as controlled modes we have discussed differ in the wires of mercury. Below.
There's that classic graph where that steep curve comes off after the pulse ox goes below 90.
Ventilation mostly differ in the way your minute ventilation or tidal volume times respiratory rate is delivered to the patient. Regardless of the mode of ventilation, adjustments of FiO2 and PEEP are the same. There are controlled modes of ventilation, hybrid modes of ventilation, and spontaneous modes of ventilation. For controlled and hybrid types of ventilation, there are two large categories of types of ventilator mode. Modes where we set the patient's tidal volume, known as volume control modes, and modes where we set an inspiratory pressure, known as pressure control modes. Within each mode category, volume and pressure, we have two subcategories, controlled or mandatory intermittent. This refers to whether we have control over every single breath delivered or not.
So I know this seems confusing, but basically all I want you to know is obviously controlled means the machine is doing 100% of the work, right? Versus spontaneous, they're breathing on their own and they're actually, starting the process. Kind of makes sense. And then there's some hybrid. Just keep it really simple. And the only other concept I want you to remember is that there's this inverse relationship between volume and pressure. Volume and pressure can be done basically for all of these, and you have a choice. So some ICUs or critical care docs will be all about volume control, That's usually the easiest one to understand, and there's a little graph here I'm going to show you, but that's all I want you to remember, and then you'll see the next part.
We will start with volume control modes. There are two main types of volume control modes of ventilation: assist control volume control, or ACVC, and synchronized intermittent mandatory ventilation volume control, or SIMV-VC. Let's start with ACVC as our mode. Since this is a volume-controlled mode of ventilation, we will first set the tidal volume. We will then set our respiratory rate and then our FiO2 and PEEP. Let's say our settings are ACVC with a tidal volume of 500 cc's and respiratory rate of 10. If our patient has no drive to breathe over this setting, or is paralyzed and therefore unable to breathe over this setting, then every 6 seconds, or 10 times per minute, the ventilator will deliver a breath to our patient of 500 cc's. If our patient wants more minute ventilation than this, if he or she tries to breathe more than 10 times per minute, then on ACVC with our current settings, the ventilator will allow the patient to take additional breaths, but we will control the volume of these additional breaths. Say our patient wants to breathe 14 times per minute. He or she will now be breathing 14 times per minute with every single delivered tidal volume staying at 500 cc's according to our settings.
So that's important. They're showing you on this side of the blue line, if they're totally sedated, they can't breathe at all, and you decide to set it at 500 cc's volume for 10 times a minute, that's exactly what they're going to get. 10 times a minute, 500, or each breath will have 500 cc's. But let's say then they start to wake up on their own, but they're still on the same setting. So now they decide to increase their breathing rate to 14 on their own. So every breath that they initially start to take on their own, all 14 will have that fixed number breath of 500 cc's at tidal volume.
For SIMV-VC, we will again set our tidal volume, as this is still a volume controlled mode.
This is very similar.
We will set our respiratory rate, the FiO2, and PEEP. And additionally, we will set a pressure support. Let's say our settings are SIMV-VC with a tidal volume of 500 cc's, respiratory rate of 10, and pressure support of 5. If our patient has no drive to breathe over this setting, or is paralyzed and therefore unable to breathe over the setting, then every 6 seconds the ventilator will deliver our 500 cc tidal volume to our patient. If our patient wants more minute ventilation than this is where you will see the difference between ACVC and SIMV-VC. Now, the ventilator will again see that the patient is trying to take a breath on his own, but instead of delivering an extra 500 cc's tidal volume every single breath like we do in ACVC, in SIMV, the ventilator will now let the patient take whatever tidal volume he can with a given amount of pressure support we have set for any breath over 10 that we have set per minute. Pressure support can be thought of as an assist or boost to the patient's own effort. So, our patient will continue to receive 500 cc tidal volume breaths at 10 times per minute, which will be synchronized to our patient's respiratory efforts. But the additional breaths will have unknown tidal volumes depending on our patient's effort and strength, with the assistance of our pressure support.
Just to quickly, this is very similar to AC. Everything that you saw before, if they're breathing 10 times a minute, you set that, they will get 500 cc's of tidal volume every time. But then let's say they start to wake up from their sedation. In this mode of SIMV, if they decide to breathe 14 times more than the 10 that you set, every little breath that they take on their own will not get the full 500 cc's like you saw in assist control, but will rather be supported by a touch of pressure support, a little bit of a boost like they said. But they will control how much volume, their tidal volume, on those breaths, extra breaths on their own. They will still always continue to get the 10 breaths that are 500 cc's, but that's the difference. They're not getting a full 500 here. So you can think of this as almost a weaning mode. So you start out with AC, and then you can switch them over to SIMV as they wake up more to get them back to their natural states. Is everyone with me? That's the take-home message of here. Now I'm only going to show you, I think, a little bit more and we're done with this.
Volumes depending on our patient's effort and strength with the assistance of our pressure support. With these two volume control modes of ventilation, we have set the tidal volume and respiratory rate. Unknown variables include the actual respiratory rate and airway pressures generated. When you are reporting values on a patient with the volume control mode, you should report your ventilator settings and also the measured variables, including patient respiratory rate, peak airway pressure, and plateau pressure. These measured pressure variables will be easier to understand after we talk about pressure control modes of ventilation next.
Okay, I think I'm just going to stop it there. That's the take-home message. If you remember nothing else about ventilators, I think I've given you just what you need to know, the basics. And here, a little bit more than you want to know. I'm not going to ask any questions on this, but I'll tell you the one slide that I will give you questions on. You just hold that thought for just a second. So if you want to be a little more technical, if you're working in the ICU, this is what the respiratory therapist, there's different components of the inspiratory flow generation, cycling, triggering, mode, beep. I've given you the information about all of it, but you don't need to know this, only if you're going into it. But the tidal volume is important. And this number 8 is the magic number that you've already seen that I want you to know. Many of the older books write it as 8 to 10. Many of the newer books, and you'll hear this next week, is 6 to 8. So I just want you to remember the number 8. If you remember one number of 8 mLs per kilogram, that's what's most important, the volume, if you're going to be doing volume. Cycling is just a mechanism in which the ventilator changes between inspiration and expiration. Triggering is when it kind of switches from one cycle to the other. And the 3 ventilator modes are these. You all understand assist control now, you saw it. You all understand SIMD, you saw that when they take a little extra breath, it's kind of a weaning mode, I think of it there. The one we didn't really talk about was pressure support, and that's in there also. That's a pressure-based system. It's not a volume, it's a pressure-based. And I've given you a little bit more about each of these 3. Assist control, it's mostly done by volume cycle there. It's commonly used when mechanical ventilation is initiated in patients with acute respiratory failure, and it's mostly used in all the medical and surgical ICUs. Pressure support is a little different. It provides a preset level of inspiratory pressure, not volume. Your volume will be calculated by the machine and determined by the patient. So you don't set the volume at all. You just set the specific pressure. Sometimes people do better on one mode versus the other. It's not worth getting into all of this right now. That's just critical care stuff that you'll learn if you go in the ICU. And this can be used also as a weaning process. But SIMD is frequently done also. It delivers either the volume cycled or time cycled, and the patient can breathe spontaneously on their own. So this is the one slide that I think I want you to know. I've highlighted what's kind of important. SIMD mode is there's less interference with normal cardiovascular function, just being more of a cardiac puncture, cardiac surgery. You can see why a lot of cardiac surgery places like SIMD. It has to do with the hemodynamics of the patient, and it's less problems with that. And you all understand what the assist control on SIMD is on that graph now. So PEEP, you heard about that. Normal PEEP is about 5. If you're going to add PEEP to the ventilator, it's 5. The one condition where it needs to go up is ARDS, acute respiratory distress syndrome. This is when the alveoli are all flooding with fluid. They're not working like they can. You can't get oxygen or CO2 across the membranes, and the increase of PEEP will help push some of that fluid out. Helps for atelectasis as well. And your guidelines. This is another wink, wink, very, very important slide that I want you to know. So FiO2 initially, when you put a patient on the vent, is going to be at 100%. We document that as 1.0. So if you see a number 0.4, that would be 40% FiO2. If you see 0.7, that's 70% FiO2. But that's how we write it. We don't usually say 100% or 40. Sometimes we document it in our notes that way because it's easier to understand for nurses and other people, but it's really written as 1.0 is 100%. Then we titrate it down to maintain that SpO2 of about 92 to 94%. The tidal volume, the number I told you to focus on, is 8 mLs per kilogram. And in ARDS, you need to go down in that number to 6, believe it or not. And then the respiratory rate is about usually 10 breaths per minute. So you can say 15 to 12, I just remembered is 10. And your standard PEEP on all patients will be 5. So there is, I'll come back to the blood gas sheet in a second, but what I want to show you is this chest tube insertion.
This is a video in clinical medicine from the New England Journal of Medicine.
Sound technique and safety are only pneumothorax in a patient on positive pressure ventilation. Hemothorax,
Why would you put a chest tube in?
recurrent or
Obviously,
symptomatic large pleural
chemo,
effusion, empyema,
pus pockets,
and
empyema,
chylothorax.
chylothorax.
There are relative contraindications, mainly based on hematologic abnormalities, such as bleeding diatheses or coagulopathy. Blood products or coagulation factors may need to be transfused in order to reduce the risk of bleeding during the procedure. The procedure should be explained and consent obtained whenever possible from the patient or next of kin. A chest X-ray should be performed when possible prior to the chest tube insertion. Sterilized and fully prepared chest
Where'd you
tube
scan that chest X-ray? Sternotomy, yeah, I see some wires right over here. You see the wires? I think you can see on that. Sternotomy patient. So it's got some effusion going on, pleural effusion or blood.
A sterile gown, mask, and gloves. Sterile drapes or towels. Local anesthetics such as 1% lidocaine, chlorhexidine cleaning solution and sterile pieces of gauze, 25 and 21 gauge needles, 10 cc and 20 cc syringes,
This
a
all comes in
scalpel
a kit.
with size
You
11
get all of
blade,
this when you
which
open up
should
the
be
kit.
on the chest tube tray, at least 4 or 5 dissecting instruments such as Kelly curved clamps or artery forceps, which should also be found on the chest tube tray. Non-absorbable strong sutures of size 1.0 or greater made of silk or nylon, a chest tube of appropriate size, a sterile drainage system, and dressings for the tube after insertion. The chest tube is sized according to its internal diameter. The length of the tube is marked with numbers to indicate distance into the chest wall. Additionally, there are several drainage holes at the distal end. A radio-opaque stripe runs along the length of the tube and out.
So there's a white line. It's hard to see here. Radio opaque. You'll be able to see that on X-ray. What's interesting is the last hole is always put in the middle of that. So you can see the break. When you'll see it on a chest X-ray and a chest tube is there, you'll see this line, and then you'll see a break in the line. That's where you know the hole is, the most proximal hole is. So if that is outside of the skin, obviously they could be sucking air in there. So that's kind of important to know, and that's how they devise these chest tubes.
Lines the most proximal drainage hole. This is used to confirm correct placement
Right
of
there.
the chest tube in the pleural
So
space
you know it's inside the chest there, because you can see that break.
on a chest X-ray. Choosing the size of chest tube is based on the indications for the tube. In the case of a large pneumothorax in a clinically stable, spontaneously breathing patient, chest tubes with an internal diameter of 16 to 22 French may be placed. In a patient with a large pneumothorax who is clinically unstable, the same rules for chest tube sizes apply. However, if the patient has underlying lung disease, requires mechanical ventilation, or is anticipated to have a large air leak, larger tubes from size 24 to 28 French are recommended. In order to drain a viscous hemothorax or empyema, or to evacuate a pneumothorax in a patient receiving mechanical ventilation, larger diameter tubes sized 28 to 32 French are more often employed. Newer evidence favors the insertion of smaller size 10 to 14 French catheters, or pigtail drains, for the drainage of pneumothoraces in clinically stable patients, and for malignant pleural effusions. This is done using a Seldinger technique with a guide wire, and often with ultrasound guidance. This technique differs from that used for larger chest tubes, and will not be discussed further in this video. Once the chest tube tray is open and all the key instruments are identified, occlude the proximal free end of the chest tube with a clamp or forceps. Next, with another clamp or forceps, grasp the distal end of the tube. This will aid in passing the tube through the tract. patient should be positioned either supine or in the semi-recumbent position. The ipsilateral arm may be maximally abducted to the side of the patient, or, alternatively, positioned behind the patient's head in order to have optimal exposure of the insertion site. The ideal location for the placement of a chest tube is in the triangle of safety, the anatomical region defined by the lateral border of the pectoralis major muscle anteriorly, the mid-axillary line posteriorly, which is also the anterior aspect of the latissimus dorsi, the apex just below the axilla, and the horizontal level of the nipple inferiorly. The nipple line may be an unreliable landmark for female patients due to breast tissue. To help with landmarking, remember that the triangle of safety should approximately lie between the 4th and 5th intercostal space in the anterior axillary line. Start your landmarking by localizing the clavicle. Next, count the rib numbers as your fingers traverse down the anterior chest wall. Once the correct intercostal space is found, move your hand along the space laterally towards the anterior axillary line. The incision will be made here. The chest tube will actually be inserted 1 interspace above this point. Mark the incision spot with the imprint of the back of a needle or a pen marking. Once full barrier precautions are employed, use the chlorhexidine cleaning solution and sterile gauze to create a large sterile field on the patient's skin. Cover the field with sterile drapes so that only the procedure site is exposed. Adequate analgesia is a very important step in this procedure, as chest tube insertions can often be very painful for the patient. The skin, subcutaneous tissues, deeper tissue layers, parietal pleura, and periosteal surface of the rib below the intended insertion site must be generously anesthetized. Using the smallest gauge needle, create a wheel of anesthetic in the skin overlying the landmark spot. Using the larger needle, anesthetize the subcutaneous skin layers through the wheel, aspirating as the needle moves deeper. Anesthetize the periosteum of the rib that lies below the intercostal space where the tube will be inserted. Once the parietal pleura is encountered, a flash of pleural fluid will fill the syringe if a pleural collection is being evacuated. If a pneumothorax is being drained, the syringe may only fill with air as the needle enters the pleural space. Withdraw the needle, aspirating along the entire path. Make an incision approximately 1.5 to 2 centimeters in length above and parallel to the anesthetized rib. Introduce the curved dissecting instrument, such as a Kelly clamp, into the incision. Begin dissecting the subcutaneous tissues in order to reach the intercostal muscles. After dissecting through the subcutaneous tissues, stay on top of the rib to guide the blunt dissection. This will create a diagonal path towards the correct intercostal space. When using a larger chest tube of sizes 24 French or greater, use your index finger to explore the tract being created by blunt dissection. This is done to ensure the larger caliber tube will be able to pass through the tract. Once you have dissected through the subcutaneous tissues and deeper intercostal muscle layers, you will encounter the parietal pleura. Push the clamp gently through the parietal pleura. The entry into the pleural space through the parietal pleura is felt as a give or a sudden release of resistance. Alternatively, you may use your finger to penetrate through to the pleural space. Once the pleural space is entered, use your index finger to ensure the lung is not adherent to the chest wall, which may impede passage of the tube into the pleural space. Often, pleural fluid will trickle out through the tract, further confirming entry into the pleural space. Pass the tube through the incision, unclamp the jaws of the Kelly, and then direct the tube through the tract slowly, using your finger as a guide. If the tube is meant to evacuate a pneumothorax, aim it apically towards the top of the lung. If the indication is to drain fluid, aim it basally towards the bottom of the lung. Make note of the depth the tube has passed by keeping track of the numerical markings on the side of the tube. Secure the chest tube to the skin using the heavy sutures. Simple interrupted or mattress sutures are often satisfactory to ensure stability of the tube and avoidance of air leaks around the tube. The free ends of the sutures are wrapped around the tube and tied multiple times to secure it in place. Purse string sutures are not recommended as they yield poor cosmetic results and increase the risk of skin necrosis. Once the chest tube has been secured, a petroleum-based gauze dressing should be wrapped around it. Apply several pieces of sterile gauze around the tube. Secure the site with multiple pressure dressings. A chest X-ray must be done to confirm correct placement. On an X-ray, the radio-opaque stripe is visible with an interruption indicating the position of the proximal hole. This hole must be within the pleural space. Otherwise, it is sitting outside the pleura and not draining effectively. This is an indication to replace the tube altogether. Do not advance the tube into the chest, as this can introduce non-sterile tubing into the chest cavity. Before unclamping the free end of the chest tube, firmly connect it to the sterile drainage system. Now, unclamp the free end. If pleural fluid is being drained,
It's an area that sometimes in the middle of the night comes loose. So nursing is usually really good at securing this, and they're going to double and triple tape it to make sure it doesn't come off.
if pleural fluid is being drained, the fluid level in the drainage system will rise. If a pneumothorax is being evacuated, air bubbles will appear. Do not reclamp the chest tube while there is bubbling. This may lead to recollection of a pneumothorax and may even result in a tension pneumothorax. Most commercially available drainage systems use the 3-bottle model of closed drainage and suction.
All right, I'm going to stop it there. You can watch the rest later. That's, I was never shown when I was in PA school how to do this. It was kind of on-the-job training, but I think it's good to at least have seen it once. And there's only one other thing here, and I'll just tell you right now, I'll be nice, I won't put any questions on blood gas. But this sheet, there's a little video that's really, really good. And I've looked at about 24 ABG videos. I think this one is the best that summarizes the 6-step approach. You guys probably have never been told in renal about the delta, the anion gap, but to make it simple, or more simple, I tried to, did I give you the ABG sheet? No. I'll upload it. I have it on my computer. I will not give you any questions on Monday on ABGs, but if you're going into hospital medicine and you want to know how the nephrologist, how the ICU doc really evaluates, and I don't just mean the simple respiratory acidosis, metabolic acidosis, the compensatory mechanisms. You can have 3 things going on at once, and this is a way to figure out all 3 things that are going on, 2 acidoses and 1 alkaloses at a time. So that short video, it's only like I think 10 minutes long, as well as that one sheet is really all you need to know for your clinicals on what you need to know for that.